Hey everybody. So this first part that we are going to be looking at is going to be about fluid balance. And remember, your role as a nurse is how are you going to manage this patient? What are your assessments going to be? What do your lab values look like? And what are your um, interventions and evaluations of those interventions going to be for your patient. So this kind of gives some background, make sure you have an understanding what's going on internally with your patient, but really when you are looking to prepare for your test, it's going to be how are you going to apply this information. So let's go ahead and get started here. So just to kind of give you some background to remind you, when you're looking at the amount and the composition of the fluids that are in the body, majority of it are going to be in the intracellular versus the extracellular. And the extracellular is what we actually look at when we draw labs on a patient. What is moving around in the extracellular fluids and water of a patient versus what is actually sitting in the intracellular. So remember that going forward when we're looking at labs, it's going to be what is in the extracellular because that is what's going to be of use to a patient at that time. I usually go over this more in class, but just to give you an idea, when we're talking about tonicity and solution, when we're using different solutions with patients, this is what actually happens to the cells. So when we use an isotonic solution, there's typically no change to the cells. The isotonic solution is going to increase the amount of fluid that's in the extracellular. As opposed to when you give a patient a hypertonic solution, you will see here how these cells have shriveled, and this is going to be what's in the intracellular. So it's actually going to pull fluid out of the intracellular to pull it into the extracellular. So water rushes out and the cells will shrink. When you give a patient a hypotonic solution, water will actually rush in and the cells will grow. Some students have related this when you think of hypotonic, think of a hippo, large cells will increase. Or as you will see the O, I think O kind of looks like a cell. It will increase the cell. So however you want to look at it, that is what we're talking about. When we are using different types of fluids with patients, you're looking at the tonicity in the solution and what and how the effect that it will have on the cells. So hopefully that helps. And this is a good picture to have. You don't have this one in your PowerPoint. It's typically something that I will draw on the board and go over in class. So hopefully you are watching this video and that it helps you out. So remember that within the body, there's going to be different things that actually help regulate the shifts of fluid in the body. So different components are going to be osmosis, which is a movement of water by a concentration gradient that it will move from a low to high concentration. Tonicity, again, talks more about the force. So it's the ability of the solutes to cause an osmotic driving force that promotes water movement from one compartment to another. So the solutes don't actually move. It is about the amount of force that it creates that moves water from one compartment to another. Diffusion, on the other hand, is the natural tendency of a substance to move from one area of higher concentration to one of lower concentration. So you will see movement of solutes going from high to low. Renal filtration, this is going to be the kidney system. Your kidneys will either kind of reabsorb, filter fluids and solutes back to the body, or make the determination to excrete it. And then, of course, we have our sodium-potassium pump, which is very important. Lab values that you need to have an understanding, osmolality, that talks about the concentration of fluid that's affected by the movement of water between fluid compartments by osmosis. Our urine-specific gravity, make sure you know your ranges there. Our BUN, which is blood urea nitrogen, normal values are 10 to 20. When I was in nursing school, hopefully this may help some if you have a hard time remembering your BUN. I would say that it would take about 10 to 20 minutes to make buns in the oven. So that might help a few of you. Creatinine, normal values, 0.6 to 1.4, and your hematocrit normal values are going to differ from men to women. This is going to look at concentration. So obviously the higher the hematocrit, it's going to talk a little bit more about the less amount of fluid that a person has. So you'll see a higher hematocrit in patients who have fluid volume deficits. So question 1, an ICU nurse has ordered to infuse a hypertonic solution. This solution will increase the number of dissolved particles in the patient's blood, creating pressure for fluids in the tissues to shift into the capillaries and increase the blood volume. What term is described by this process? So again, we're talking about a hypertonic solution is going to pull water out from the cells into your extracellular fluid, and that's going to be a shift known as osmosis. Osmosis, again, is movement of fluid from a region of low solute concentration to a region of high solute concentration. So if a patient doesn't have a lot of fluid in the extracellular, if you give them a hypertonic, it's going to pull more fluid from the intracellular to the extracellular. So moving from a low solute concentration to one of high across the semipermeable membrane. Hydrostatic pressure refers to the change in water or volume related to water pressure. And remember that active transport is the movement of molecules against a concentrated gradient. So it's kind of going against the grain. Diffusion, remember, is movement of solutes from an area of greater concentration to one of lesser. And I did post a couple of videos. I do hope you watch them. They're very short. One kind of gives an example of osmosis kind of in real life, so you can visualize it. And in terms of diffusion, it will be the Skittles experiment. So osmosis is the gummy bears and Skittles is the diffusion. Remember, overall, when we are dealing with patients and we're talking about fluid balance, there are many organs within the body that are actually going to affect how the body manages fluid. It's going to be everything from the kidneys to the lung, the heart, adrenal glands, parathyroid glands, and pituitary gland. Different conditions that are going to affect this we will cover during the duration of this course. So this was just a friendly reminder again to look at those videos about the gummy bears and also the Skittles. I figure the nice rainbow color of the gummy bears kind of remind me of Skittles. So Skittles, that experiment will relate to diffusion, where if you look up gummy bear experiment, that will show the process of osmosis. You can actually do these at home. They're kind of fun, and especially if you got little ones. So there's a couple different slides. This is going to be your snapshot or your overview of hypovolemia, also known as fluid volume deficit, FVD. So here, when we're talking about the volume, you have a loss of your extracellular fluid volume. It tends to exceed the intake of fluid that a person is actually taking in. There's a decrease in isotonic fluid, again, what is within the ECF. Osmolarity, there's a change in distribution of solutes. It could either be caused by hypertonic or hypotonic solution. There's a possibility of hypernatremia, which typically happens when there's a loss of water. But there can also be hyponatremia when there is water excess or intoxication. Multiple systemic signs and symptoms go along with hypovolemia. Treatment usually consists of isotonic or hypotonic IV solution. And when we talk about nursing care, we're going to be talking about monitoring a patient's fluid balance, performing frequent vital signs, and assessing that patient's skin turgor. So some risk factors, you will notice when I do presentations, I like to have pictures that kind of help go along with the words. So there are many things that can happen to a patient that can put them at risk for hypovolemia. Everything from strenuous exercising, increase of caffeine and alcohol, these are diuretics, living in high elevations or in dry climates, Also, you have to remember our elderly population. So when you have questions on NCLEX, remember how I point out if a question gives you a specific age of a person, it probably is relevant to what the question is asking. So if it gives you a patient that is 65 years or older, and it's talking about fluids, you should take into account that elderly patients can have some issues because of elasticity of their skin. They can just natural progression, aging, kidneys don't work as well and have issues with glomerular filtration and concentrating the ability of the kidneys. They also can have some loss of muscle mass, and muscle tends to hold more body water, and sometimes they just have a diminished thirst reflex. They don't feel thirsty. Also, other things that can cause hypovolemia: loss of water and electrolytes through vomiting, diarrhea, fistulas, fever, excess sweating, burns, blood loss, gastrointestinal suctioning, and third space fluid shifts. Remember, third spacing, the best way to kind of imagine it, it's kind of like the black hole of the body. When fluid goes into compartments in the body, this is known as third spacing, and these are areas where, say, the abdominal cavity, that fluid is no longer of use to the body anymore. So this is called third spacing. Decrease in intake, anorexia, nausea, and ability to gain access to fluid. There are some conditions that we will touch upon in the endocrine section, like diabetes insipidus, and uncontrolled diabetes mellitus can contribute to a depletion of extracellular fluid volume as well. Signs and symptoms: acute weight loss, decreased skin turgor, decreased fluid excretion, so oliguria less than 400 mLs per day. Urine's going to look concentrated. Patient can have a weak rapid pulse, prolonged capillary refill time, a low CVP, low blood pressure, orthostatic hypotension, flattened neck veins, dizziness, weakness, thirst, confusion, and elevated pulse, muscle cramps, and sunken eyes. Lab values will see an increase in hypovolemia. BUN will increase due to the hemoconcentration. You'll have a high urine-specific gravity, again due to concentration. Serum sodium greater than 145, and serum osmolarity greater than 295. And remember, again, this is looking at concentration of solutes with the osmolarity. So if a person has less fluid on board, they're going to have a higher osmolarity. Also, too, one thing I want to point out is that when a person is becoming hypovolemic or having hypovolemia, oliguria isn't just because they have less fluid, but it's another way for the body to try to preserve whatever fluid it has. So the body will excrete less fluid. A life-threatening complication will be hypovolemic shock. You'll cover this more in critical care, but just so you have an understanding that it occurs with a significant loss of body fluids. The client's mean arterial pressure will decrease, which slows blood flow and perfusion to tissues of the body, and the cells are no longer able to carry oxygen to the blood adequately, and this is due to the loss of red blood cells. So this is life-threatening. And signs and symptoms you will see in these individuals is that their blood pressure can decrease, but their pulse rate is going to increase. Because again, this is, the example I always give is if somebody's leg was chopped off and blood is gushing out of their femoral artery, the heart doesn't really know that that has happened. All it senses this decrease, where the blood pressure will drop, and so it increases its rate to try to compensate. But unfortunately, it is futile unless that bleed can be stopped. So you will see the basically blood perfusion starts to slow to the tissues, and oxygen cannot be adequately sent to the rest of the body. Now remember that hypovolemia is not the same thing as dehydration, so these terms should not be used synonymously. Dehydration simply is water loss alone. So is the following statement true or false? A patient who's experiencing hypovolemia is likely to have a weak, rapid pulse and hypotension. True. Hypovolemia often results in a weak, thready pulse with a rate that is higher than normal. At the same time, the patient is likely to have low blood pressure due to low vascular volume. So the flip side, fluid volume disturbances, if we're going to talk about hypervolemia or fluid volume excess, this is when there's an isotonic expansion in the ECF caused by an abnormal retention of water and sodium in approximately the same proportions in which they normally exist in the ECF. It manifests with edema, distended neck veins, crackles, tachycardia, and increased blood pressure. Treatments will include diuresis and fluid and volume and sodium restriction. Nursing care, you need to focus on the patient's daily weights and assessment of edema. Remember, daily weights, you want all the conditions to be the same each time every day, so that way you can get an accurate assessment of the patient's daily weights. So some of the risk factors for hypervolemia can be for those who have compromised regulatory systems such as heart failure, kidney disease, and cirrhosis, overdose of sodium concentrated fluids, also fluid shifts that can occur following burns, prolonged use of corticosteroids, which is also the same as prolonged corticosteroid therapy, severe stress, and hyperaldosteronism. And in terms of severe stress, that has a lot to do with the stress response in the body and the hormones that actually are released during stress have the same reaction as, say, corticosteroids, and so therefore it will hold on to fluid. So some of these pictures here, nursing school, just reminds me that we're all going to be holding on a little bit of fluid. Hypervolemia signs and symptoms. So if you look at vital signs, tachycardia, bounding pulse, hypertension, tachypnea, increased central venous pressure. When we talk about neuromuscular, we're going to see weakness due to excess fluid retained, which can deplete the energy in a person and increase the workload of the body. They can have a headache or altered level of consciousness. Gastrointestinal, some patients may have ascites. In terms of respiratory, may hear crackles, cough, increased respiratory rate, dyspnea caused from an excess of fluid within the body and lungs. And other signs can be peripheral edema due to an excess of fluid within the body and lungs, resulting in weight gain, distended neck veins, and increased urine output. When we're looking at labs, you're going to see decreased hematocrit and hemoglobin, decreased serum and urine osmolarity, decreased urine sodium and specific gravity, and decreased BUN due to plasma dilution. So a lot of these signs and symptoms here is going to greatly vary based on the severity of the hypervolemia. So you're not always going to see all of them with all patients. The life-threatening complication when we're talking about fluid overload is going to be pulmonary edema, and this is essentially somebody who is drowning within the lungs. It is caused by severe fluid overload. Manifestations include anxiety, tachycardia, increased vein distension, premature ventricular contractions, dyspnea at rest, change in level of consciousness, restlessness, lethargy, ascending crackles, which is the fluid level within the lungs. So say somebody who may have pneumonia, you typically just hear crackles in the base. This is where you're going to hear increase crackles as the fluid level increases in the lungs, and cough productive of a frothy pink tinge sputum. So this is basically the bulk, a quick overview of fluid volume deficits and overload. Again, make sure you have a good understanding of your nursing interventions, know your labs, and your assessments and interventions for both fluid overload and fluid deficit. That's it.